Well, welcome everyone. This is the formal welcome, as we've had some informal welcomes. I'm so glad to have you join us today. And I'm especially delighted to introduce my good friend and colleague, Swati Satturwar, who is a pathologist, associate professor at the Ohio State University. And she, previous to joining the faculty there, completed two fellowships in cytology and GU pathology at the University of Pittsburgh, another very noted and esteemed institution. Prior to that, she did some training and research fellowship in Canada, a residency in pathology in East Carolina, and her medical training and a pathology residency in India. So she has really been through years and years of training to come to this point and share with us things tonight. And so with that, I'm going to mute myself and turn the microphone over to her to share her cases. And as we do so, please, if you have questions, write or type your questions into the chat box, and we will answer those questions at the end or as we go along. But we want this to be interactive, and I know some of you have seen the cases in advance and will be able to comment on them. So, Swati, the floor is yours.
Yeah, thank you so much, Dr. Hazel. I really appreciate this opportunity and really excited to see all the people from overseas, too far. First of all, I would like to know how many of you are trainees because I would like to go over the basics before I go over the cases. If most of you are trainee, then I would just go over the PowerPoint with some basics and then we can start the cases. So. Um, so,
If you can
okay,
raise your
let me
hand if
go
you're
with
a
this.
trainee. I think V is in his third or fourth year of training in Hue.
Okay,
I don't know about Maria or
it's okay.
Ouhean.
Okay,
Yeah,
okay. So I think I'll go over the.
always a good idea. Unmute yourself.
Yeah, sorry. Yeah. Are you able to see the screen now? Yeah, so you can see, one in eight men will get diagnosed with prostate cancer in their lifetime, and these are the all incidences from United States. And when it is a localized disease, 5 year survival is great, and when patient have distant metastasis, the 5 year survival becomes worse. This is uh, gross pathology, so here you can see prostate cancer typically occurs in elderly people. So you have a lot of BPH nodules, and then this is might be a focus of cancer. Prostate cancer is one of those cancers where you may or may not see the cancer grossly every time. This is another picture here. Again, you can see a lot of BPH nodules. Um, then for screening of prostate cancer, typically two tests are done. So serum PSA is the most important one. Here in United States, screening starts at age of 50, and any PSA level greater than 4 gets a prostate biopsy. And then clinically, you can do digital rectal examination. So these are the basic tests. Um, and then you can do imaging for prostate that includes ultrasound, MRI, PSMA PET scan, bone scan, CT scan. So first people would go for ultrasound and then MRI. So for MRI, we have what is called as a PIRAD score. It is a prostate radiation radiology score that is from 1 to 5, as you can see here. If the score is 1, there is highly unlikely that there is going to be a clinically significant prostate cancer. And when you go to PIRAD score of 5, then more likely risk of having significant prostate cancer. Then indications for prostate biopsy include increased PSA, clinical symptoms, and family history of prostate cancer. So I would say in United States, most common indication is still increased PSA. Then it is important to know how do we do prostate biopsy. So transrectal is the most common route because you get all the carryovers or contamination from the route that you do prostate cancer. Sometimes you can do prostate biopsy using transperineal route and very rarely transurethral. Then we talk about the prostate biopsy as the first and the most important diagnostic test. Here you can see that biopsy is gold standard for diagnosis, and on the right side you see the image. So here this is called as a targeted biopsy, where the images from the ultrasound as well as MRI are fused in real time and the area is targeted. And we talk about the PIRAT score. So targeted biopsies are for the scores with high risk of prostate cancer. And then we do ISC as needed for the diagnosis. We will go over the cases, and you will know how we use ISC. And then before going over the cases, I definitely want to talk more about the diagnostic features. So according to WHO fifth edition, there are essential features and then there are non-required or non-essential features. So essential features include malignant glands, infiltrating stroma. Every single word, every single line is important here. An absence of basal cells and nuclear features including enlargement and hyperchromasia. Desirable features include cytoplasmic features. So we will go over all of these because prostate cancer is a diagnosis is not you will have all the features in one case. So it is a combination of features that you use for diagnosis of prostate cancer. So in the cytoplasm can be amphiphilic or abundant pale. Then prominent nucleoli. In the lumen, you can have crystalloids, mucin, amorphous pink secretion. And then the bottom three are the specific features. They are pathognomic of prostate cancer, but they are not sensitive. So perineural invasion, mucinous fibroplastia, and glomerulations. And prostate cancer is given Gleason scoring, and then the Gleason scoring now is divided into the grade groups. So we will go over the Gleason score, but grade group are now clinical grade groups from 1 to 5. And here you can see Gleason score 6 or less. Then Gleason grade group 2 is Gleason score 3 plus 4, and grade group 3 is 4 plus 3, and then 4 and 5 are high risk. So grade 1 is low risk, group 2 and group 3 are intermediate risk, and group 4 and 5 are high risk. Now these are the features. So here on this is a benign prostate gland in the background, and then infiltrating in the stroma. So pink is the stroma, and these are the malignant glands. So shape of the glands goes on decreasing in size. Then you have prominent nucleoli, eosinophilic secretions, and absence of basal cells. So that's how we define prostate cancer. Then this is another image. Here you can see acini. Here the feature is straight luminal borders, eosinophilic secretions, and then again infiltrating in the stroma, prominent nucleoli, and back-to-back glands. Next one is another prostate cancer. Here in the cytoplasm, you can see the cytoplasm is more eosinophilic or amphiphilic. In the lumen, you see this pale blue mucin. All of these are features, again, straight luminal borders. Some of them do have prominent nucleoli. And then the arrows are directing towards the crystals. And then again, in the background, you have 3 plus 3 Gleason, 3 plus 3 cancer there. And then these are the pathognomic signs. So here, this is a big peripheral nerve, and you can see the perineural invasion. So in prostate cancer, we typically like to see what is circumferential, as you can see here. So circumferential should be at least greater than 50%, or then intraneural, as you can see here. To call it a perineural invasion. In other cancer types, even if it is focally invading the nerve, you call it perineural invasion. But in prostate cancer, you want to have a circumferential invasion. So this is called as collagenous mucinous fibroplasia or collagenous spirulosis. So these are collagen spirules, and then here you can see a little bit of mucin. So this is also pathognomic, and if it is present, you should hunt for more cancer. Glomeruli gland. So by name, you can see that this exactly looks like glomerulus of the kidney. There is a tuft of tumor cells attached at one end, and it can be, so this is small glomeruli, this is large glomeruli. All of the glomeruli forms are considered as Gleason score 4. This is another example of 3 plus 3 back to back glands. Here you have some crystals, but in this one there are cytoplasmic vacuoles. So in real life, you should ignore these cytoplasmic vacuoles and call it 3 plus 3, not over call it as 5. Okay. Then a little bit about Gleason grading evolution. So original was described in 1960. It was modified in 2005. Then another modification came in 2014, and then now we have a little bit more modification in 2020. So here you can see different Gleason's patterns. So it is architectural based score given to prostate cancer. So the major changes that I would like to highlight include, so here you can see the cribriform, small cribriform, they became pattern 4 in the recent, and any cribriform pattern now we call them as pattern 4. And then all of the other things still remain the same. And on prostate biopsies, you cannot give Gleason score 1. We will go over that very shortly. So this is a well circumscribed nodule. You can see here the similar to like the shape of the glands is similar. In Gleason score 2, you have some glands infiltrating at the edge. And then Gleason score 3 is glands infiltrating in between the benign glands. And then 4, 5, we will go over that very shortly. So 4 is so small cribriform, large cribriform, glomeruloid, small fused gland, and poorly formed glands. So poorly formed glands are the most prone for interobserver variability. And then we have pattern 5 with comedonecrosis. So let's go over the active surveillance. So on biopsies, we give primary score as the most predominant score, and the secondary as less predominant. We just add those two. And on needle biopsy, if a higher grade score is present, even if it is less than 5%, we add it to the most predominant score. So we will go over cases. So this is a prostate PIN ISC. It is a cocktail of high molecular weight cytokeratin P63 and AMEC or raceme. So here on the top, you see all these are the benign glands. So P63 is nuclear and high molecular weight cytokeratin is cytoplasmic stain. So intact basal cells in benign glands and absence of basal cells in malignant glands. So with this background, let's go to the cases now. So I will like to go over some, I would like to start from case number 6 actually. So are you able to see the screen still? So now I am opening the cases of unknown slides. Are you able to see that? Okay.
Yes, we can say
Okay, okay, good. Okay, so before going to the case, so all of the cases are from patients who are men, who are elderly, and who all have elevated PSA. So that is going to be the history. So I'm not going to tell the history every time. And then basis of pathology is to know how the normal looks like. So until you know what normal looks like, you really cannot say what is abnormal. So the first case I'm going to show is essentially normal. I already told you, but I would like to go over the case. So here in this image, you can see there are 2 cohorts and there are 3 levels. So at OSU, we do 3 levels. In United States, most of the institutions do 3 levels. In OSU, we put 3 levels on a single slide. In other institution, you will have 3 slides for one site of the prostate biopsy. Okay. So on low magnification, so we just learn about the features of prostate adenocarcinoma now. On low magnification, we really need to look for something that is infiltrating in the stroma. So this is benign. So pink is the stroma here, and the bluish is the gland. So at this magnification, I really don't see anything infiltrating in the stroma, but I still go over at 10x magnification and really see if there is anything abnormal or not. So now I am at higher magnification. So first and most important thing, so you can see here there are luminal cells here and then basal cells here. So two layers, even all of the glands show two layers. So and then this is a nice prostate stroma. So again, showing more of the normal benign prostate glands and stroma. So in different zones of prostate, you will have different combination of stroma as well as glands. So this is benign prostate. Okay, two layers, and even if you go on little lower magnification, you can appreciate two layers. So basal cells can look like spindle, triangular, or they can be any shape. So and you really need at least like focal presence of basal cell to consider it as benign. Okay, then I go to the next case. So anyone would like to talk about this case? So again, this is a 54-year-old man and PSA of 5.41. Is any volunteer there, or should I go over the case?
Feel free to unmute
Okay.
yourself and respond if you want to.
Okay. It's okay. Yeah, I will go over the case. Okay. So again, you can see there are two cores, three levels, and again at this magnification, I really don't see much here on this core. There is a little bit of crowding here at the top, and then I go on high magnification. So here again, this is all prostatoma. So prostate is a very special gland because in elderly patient there are multiple things going on the same time. So one, you can have BPH, benign prostatic hyperplasia. At the same time, other part of the prostate are undergoing atrophy, and then you can also have prostate cancer. So this is again part and parcel of normal or benign prostate change. So this is a stromal nodule in a prostate, okay? And then I go here in the little bit crowded area. So on this slide, I really want to mention one more thing. So these are the secretions inside the lumen of benign prostatic gland. They are called as corpora amylacia. And when they are present, it is a sign of benign. So here you can see more of this. Okay, so greater than 95% of the cases, if corpora amylacia are present, it is more likely to be a benign gland. Rarely you can have cancer with the corpora amylacia. So this area, I go here, and again, in the same focus, I have something that looks benign. And so this is more atrophic now. So here you can see the cell size has shrunken. There is cytoplasmic shrinkage, there is nuclear shrinkage, and all you can see is just one layer or maybe two layers at times, but many times you can just see one layer. And you need ISC to see the basal layer. And this is the focus of atrophy here, and then you can see the normal here. So abundant pale apical cytoplasm, and nuclei basally located, and then this is normal, but this is atrophy. Okay, but this is just to show you the variation of something, and then this core is again. You can see here, so this is what we call, so here you can see a little bit of cytoplasm. So this is what we call as partial atrophy. In complete atrophy, there is complete atrophy of the nuclear cytoplasm, nucleus as well as cytoplasm. So you just see the nuclei that are blue. And this is benign. So let's go over the next case. So this is the next case, and you can see now there are multiple fragmented cores. At this magnification, again, you start at low magnification. You look for an area of back-to-back glands infiltrating in the stroma. So at this magnification, nothing is striking out, but let's go on little bit higher magnification. So here most of this is again stroma. And then as I go here, this is atrophy. I don't see anything concerning here. And then again, more benign glands, and then again, atrophic. So you can see, in the same focus, this is normal and this is atrophic. So it is important to understand atrophy because on small biopsies, atrophy can be differential diagnosis for prostate cancer. Okay. And then there is some chronic inflammation here, as you can see. So about 50% of the prostate biopsy shows chronic inflammation in the stroma. It is, we typically don't even mention it because it is so common. And if patient doesn't have any history or any other reason or any prostate cancer on other cause, then we do mention chronic inflammation. So this is another portion of prostate biopsy here. This is again atrophic, but this is calcified calcifications. Again, little bit back-to-back glands, but we do follow the same rules. We use all the criteria to call something prostate cancer. Then we go to the next case. So, as compared to prior cases, now you have a core here. There looks like a little bit of crowding here, but this area looks very okay. And then again, we go on higher magnification. And then again, these glands are little bit atrophic. And then I go in this area. These look still fine, corpora malacia, stroma, nice corpora malacia. Then this looks all benign, and then I go here, and then this is a prostate focus of prostate cancer. So although it is very small, so this is a benign gland. Here you can see, two layers, and then more cancer here. So this is definitely prostate cancer. So what features we have here? Prominent nucleoli, the glands infiltrating in the stoma. So to call something pattern 3, we draw imaginary line. So imaginary, but I can see, I can just draw a line here. And if you can draw imaginary line surrounding each individual gland, you call it pattern 3. So it is for this biopsy, I included this one because this was, so again, if you go on low magnification, so really this is the crowded area, but corpora militia, this is little bit crowded here. So it is really essential to make sure that you look at the entire core at high magnification before calling it negative. Okay, and then we go back to this area again. So for this core again, this is pattern 3. It is important not to overcall these small glands as pattern 4 just because they look poorly formed glands on this level, and you have to always make sure that you look at all of these levels. The reason is really important because majority of the prostate cancer patients with Gleason score 6 go on active surveillance. So patients undergoing active surveillance increase every year in United States. So it is really important to have very strict criteria to call something pattern 4 on small biopsies. So again, one layer, and here you do have pale mucin, straight luminal borders, and as you can see in on this level, you can see the lumen and more well-formed gland rather than poorly formed glands. So let's go to the next one. Okay. So now this is the next case. And so even at this magnification, at this in the middle core, I see this rectal mucosa, and we go on high magnification, and you can see the rectal glands here. As I mentioned in the beginning, that you can always get contamination from the route that you do the biopsy. Okay. And then again, we follow the same rule, low magnification, we look for the crowded back-to-back land. So in this score, I see this is very crowded area. Even this one is very crowded. And then I'm not worried about the top of those scores. I go on high magnification. So when again giving the Gleason score, I can definitely draw an imaginary line. So this is all pattern 3. And again, we follow all the diagnostic features. So we really don't see any basal cell. There are straight luminal borders infiltrating in the stoma. Here in this one, you have what is called as dense eosinophilic secretions. So it is important to differentiate these from the corpora amelitia. The more you see corpora amelitia are more like bluish or purplish, and they are in the benign glands. Let me see if I can find one here. Yeah, it's not here, but it's important to differentiate from that. And then there is little bit crystal formation here. So this is, it is important not to overcall this one as 4. So if you look at different level, this is a malignant single gland. So it is also pattern 3. So this is 3 plus 3, Gleason score 3 plus 3. And then we go on this part, and then same thing. So small glands infiltrating in the stroma, single line, more of the eosinophilic secretions. And now here we have the crystals. So crystals can be any shape. So here more like a rectangular shape. You can have needle shape, any shape crystals. And crystals or crystalloids are important because typically they are associated with prostatic adenocarcinoma. And then the other part is all atrophic prostate tissue, then more like, so this is high grade pain. So we will not talk about the prostatic intraepithelial neoplasia in this session. We may talk about it in the next session with intraductal carcinoma and other. So any questions so far? So until now, we just saw the 3 plus 3. Then let me go to something. Um, 3 plus 4. Okay. So now you have 4 cores here, and even at this magnification, I can see, this is very crowded area. Even this is very crowded area. I don't see much on this score, and nothing much on this, but we will follow the same rule and we will go on high magnification. So so now we are talking about the patterns, isn't it? So this is a small acinar gland. I can still draw imaginary line. So this is pattern 3. I go on to different area. Here it gets more complex. So here it is very, very difficult for me to. So this can be considered as a fuse gland pattern. Then I go in this area. Majority of this is still pattern 3, and then majority is still pattern 3 as I move along. So, but still there was one area that was really concerning for pattern 4. And then I come here, so you still have this pale blue mucin, and this is too complex. Okay, so this is like a cribriforming architecture where you have punch out lumina, and this is still complex. So there is pattern 4 now. So you are not able to draw an imaginary line. So again, this is too complex to color. So some of it is cribriform and majority is pattern 3. So this is a peripheral nerve in the middle of the core. So you can see nice circumferential, perineural invasion. This is another cribriforming architecture. So it is very common to have cribriform architecture in perineural invasion areas. And if you have a core with only perineural invasion focus of prostatic adenocarcinoma, we typically don't grade it because the architecture is because of the perineural invasion. We mention it, and if there is higher grade cancer on other core, then it is okay to grade. But if it is the only finding, then um, it should not be graded. So again, more 3 and then some 4. So this is now we are moving into the 3 plus 4 category. And it is really important. So this is corpora malacia. You can see two two layers of cells there. And then at low magnification, so again going back to this low magnification, so this is still area of back to back gland that was not very apparent on the first time when we look at it, but this is complex architecture. And so let's say I had only this area, then I would have hesitated to give a Gleason score. But on the same site, I have more cores with 3 plus 4. So this becomes a 3 plus 4 case. Then we go to next case. Um,
I'm sorry. Could you explain the line, the imagine line you mentioned that to distinguish
yeah,
the Gleason 3 and
yeah, yeah.
Gleason 4? Can you use the notation, the built-in notation in the part presenter to visualize that line for me?
Yeah, I can draw that for you. Okay, so this is actually next case. So we will do that exercise on this case. Okay, so you can see there are four, or you can see three fragmented cores. You can go back to the gross description and then correlate with the cores. Okay, so again, at this magnification, so low magnification, I just like the really low magnification. Everything looks so busy back to back. All of these cores are involved by cancer, and I go on high magnification now. So here, so let me see if I can use the pencil. Okay, I think I can use this. Okay, so this is what I mean. Okay, so this is one. So I can draw a circle around this gland. So this is pattern three. Okay. uh, and even this one, so even many of these, okay, so but this is not okay. As I mean, I cannot draw a circle surrounding, but most important thing for the trainees to know is that you look at all the levels, because this can be but this is too complex, but not to overcall mostly the poorly formed glands. Okay, so here there are poorly formed glands like this, and there are many other, so like this. So even this becomes complex. I cannot draw a line, but this is what I mean when I say that I can draw a line around each gland. Okay, so isn't it? I can draw a line around many of these. So this is a easier example, isn't it? You really don't need to draw it like this. You just imagine it in your brain. So again, back to back land. So this is pattern three, and then so in between, so these are benign, atropic. You can see two layers. So we follow all like criteria for diagnosis, and then there is some mucin here, some eosinophilic secretions, prominent nucleoli, back-to-back glands, and it is important not to overcall. So like, so if this is like back-to-back glands, not to overcall. So here I would still call this one and this one as three, not like four, because they're just like close to each other. But if you look at different levels, you can see that they are different glands rather than fused. So here I go in this area. This is becomes more complex. I even this is this these are like areas with poorly formed gland. So I cannot see the lumen. And as of now, there is no like solid criteria what you call at poorly formed gland. That's why there is a lot of inter-observer variability. So here again, lot of glands with small lumen. Okay, pale blue mucin. So this is a pattern 3+4. Okay, and as we go here, so we still have more three. And then let's go on this score. So again, this one has the cytoplasmic vacuole. So it is again important not to overcall this one as signet ring cell and pattern 5. Okay? More three, and again same thing. So some four, and so currently we do give the percentage of involvement, core involvement. So we don't measure the length with the. So some people measure the length. We don't. We like to give the percentage, and it is easier and more like less inter-observer variability when you give percentage. So is that clear to you, V? The imaginary line.
Yes,
So more crystals.
I think I got it.
Got it? Good. Yeah. So more of those crystalloids, eosinophilic secretions. Yeah. And what else I have in this case? Yeah. So let's go to the next case. So this is so here you can see one, two, three. So this is like single core, So four cores and two levels. And again, we look at the low magnification. Nothing really stands out as very crowded area. But again, we will go on high magnification. So more like partial atrophy, with stroma, benign glands, and then I go in this area, more stroma, and then I see a lot of necrosis here. And then there are some histiocytes here. So actually, I tell you, so this is a patient with history of bladder cancer. So this is a necrotizing granuloma on a prostate core biopsy. It is not uncommon to get necrotizing granulomas on prostate cores. Here in United States, a lot of patients get bladder cancer, and they are typically treated with intralesional BCG therapy. And in those patients, it's very common to have necrotizing granulomas. So this patient was treated with BCG therapy, and here you can see more histiocytes or granulomas. This is non-necrotizing area, but majority of this one is necrotizing. Okay. Okay. So if there, let's say there was no history of BCG therapy, then in such cases you should do GMS and AFB to rule out infectious disease. Okay. So this is the next case. You can see there is one core, okay, and these are three levels. We will go in the middle core. And at this magnification, this is too crowded, until here, I think this is cancer, okay? So let's go back on high magnification. So again, three, we can draw our imaginary line. And then I have some poorly formed glands, so small lumina and not well-formed glands. And I go in this area, more of those poorly formed glands, and then some of the glands are well-formed. So this is a biopsy highlighting the poorly formed. So here I cannot even see lumen in many of these glands. So these are poorly formed glands, and it is really, really important to look at all the labels. So this is three, but in the background, even this is three, but many of the glands in the background are four. So this is the case, and then as you go here, this is more three. So again, single like infiltrating glands. So this is benign on the top, infiltrating in the stroma. Pale blue mucin, eosinophilic secretion, variable prominent nucleoli. So this is three, and here more pattern four. So overall score for this case is 4+3. Then I go to the case now, the next case. Okay. So now we look at 3+3, 3+4, 4+3, and this is another case. Okay. So there is only one core at this magnification, very crowded, almost like 50 to 60% of the core is involved by cancer. And then I go on high magnification. So this is all cancer, okay? And very complex architecture. So this is cribriform architecture, again, not exactly cribriform, but fused glands. And some of them are pattern 3, as you can see here. Some of them are pattern, so again, more 3 here. And as I go up here, more 3, and then here glomeruloid pattern. So this is glomeruloid pattern, and this is so this is a glomeruloid pattern. Sometimes you can see, and then as I go here, so this becomes, so now I don't really see any gland formation. So when you don't see any gland formation, then you are thinking about pattern 5. So here there are single infiltrating glands like this, single infiltrating cells. This is Indian file, so pattern 5 arrangement, and then this is more complex 4 pattern, and this is a nerve embedded in the middle here, perineural invasion. Um, and then again, lot of pattern 5. So here we cannot, single infiltrating cells, Indian file. So in this case, there is pattern 4, 5. So, and there is pattern 3. But as I said in the beginning, on a small biopsies, even if pattern 5 is less than 5%, you need to add it to the Gleason score, total Gleason score. So this is 4 plus 5 case, okay? So this is again no gland formation at all, okay? So let's go to the next case. Okay, now I have two cores again, like 2/3 of this core and 2/3 of this core. Looks like it is involved by cancer. I go in this area, and this is look like more like a 3+3, again, you can see, they are back to back, very close to each other. That's why you say it's an imaginary line. You should not overcall this as fuse glands. Okay, so this is 3, and you can see nice eosinophilic secretions, crystalloids. Um, and as we go here, now we really don't have any gland formation. So patternless patterns, solid shades with comedo necrosis are all pattern 5. So this is all pattern 5. Some of it can be 4. And then we do have again pattern 3, 4, 5. But again, in this case also, we will ignore the 3 and we will call it 4 plus 5. So look at that. So again, very poorly formed glands and patternless pattern. So pattern 5. So I think we have like 3 minutes left. So let's go over a couple of more cases. And um, so this is next case. Here you can see 3 cores. And at this magnification, you can see everything looks like very bluish, very crowded, even this area, entire core. So everything looks like it's a cancer, okay? And then I go on high magnification. So what do you guys think about this area? Um, so no as such gland formation. Okay, so 5, and this is a solid shade. So again 5, another solid shade 5, more solid shades, and now you have this single infiltrating cells and some cells with some again more solid shades. Some of them with Indian pile, very high grade cancer, poorly formed. So no, actually no gland formation at all in many areas. So here, so this is a 4 plus 5, or maybe there is more 5 on this one. So you can see, nice Indian file. Again, so when you have glands going in all direction like this area, stellate shape, solid shades, that is pattern 5. And then more of this. So every like this core is entirely involved by cancer. Okay, and then again more solid sheets. So this is pattern 5. And even in the background, some of it is pattern 4, but most of it is pattern 5. So Gleason 4 ply, very high grade looking cancer on this one. And so here you have more crush artifact, but given the architecture on other cores, this is likely 4 plus 5 or 5 plus 4. Again, this whole area is very high grade cancer with some of them poorly formed glands with small lumina, but most of them don't show any gland formation at all. And then, so again, corpora amylaceae, but here in the background, you can see a benign gland. Okay, let's go to one more case. And okay, so 3 cores, and again, so most of the core is involved by cancer. So it becomes very easy if you have this much cancer on the prostate biopsy. So this is something called as foamy appearing, prostate cancer. So differential diagnosis for this becomes prostatic xanthoma or xanthomatous inflammation. It exactly looks like foamy histiocytes or like granulomatous inflammation. If you have a very small focus, then you may overlook it, but it's important to do ISA if you are thinking about it. So this is five, I have single infiltrating cells. They look malignant with a foamy gland pattern, with a Indian pile, and patternless pattern, solid shades. So this is all five or some four. So it's already 9 o'clock. Do you guys have any question? Do you guys have any questions?
Swati, one of the
Um,
things I have a question. One of the things that I think is hard sometimes is refining our distinctions between 4 and 5 pattern and sometimes
yeah.
between 3 and 4. How helpful are the resources that say the ISUP's website or other place? Are there other resources that you have found that are particularly helpful to help trainees to refine and get up to the high reproducibility of their uh, classification of Gleason score?
Yeah, so I think being consistent so everybody has to find their own thresholds. So I have a very high threshold in particular. All of us at OSU have a very high threshold to call something poor, especially if it is poorly formed gland or ill-formed gland, because there is a lot of inter-observer variability and there are no black and white criteria. So if I want to call something poor that is poorly formed, I will look at the biopsy course at 10x magnification and I see that they are persistent and they are not just single glands. I should see a cluster of poorly formed glands to really consider it as pattern 4. And then when it is 4 and 5, and if you have multiple cohorts with 4 and 5, it really doesn't matter if you call it 4 plus 5 or 5 plus 4. But I do follow, like in this case, so pattern 5 is still easy, and cribriform and glomeruloid patterns are like there is less observer variability. Everyone would be at the same page because it's an architecture. Pattern 5 sometimes can be very challenging on small biopsies. Especially, you need to think about pattern 3 that is tangentially section and you just see a single, and that's why we do the levels. And then again, you can change your threshold if you see higher grade cancer on other cores. And then again, ask for any senior person, who has more experience for the cases where you have really, hard time deciding 4-5 or 4-4. Yeah, because it does change the managements. But again, as I said, if there is one more core with 4 plus 5, I really don't hesitate to call, or, to lower my threshold to call something 5. Yeah.
Yeah, I
But
think
yeah,
that's
I think
yeah,
most,
having a network of people you can ask questions like that is very, very helpful. And I think that's and especially now since we can communicate globally more readily, I think it should be very we should understand that people will ask questions, and we should give our opinions freely to help in that issue.
yeah, I sometimes talk to the clinicians. I didn't talk much about the atypical small acinar proliferations. Those are like the areas, yeah.
Yeah,
So maybe in the next session we will, talk about that. But yeah, there are, yeah, in borderline cases, I would definitely like to talk to the clinicians.
yeah. Well, this has been very, very good. Any other questions from any of the participants? I'm not sure if other
You
people
can
had
reach
this
out.
problem, but I had a little bit of a disconnect in terms of my video and audio. So I'm hoping that the recording will come out good. But if other people had that problem, let me know.
I would like to
I
thank
have that
everyone.
problem too.
Okay. Well, we'll let the recording run so you can mentally adjust to come back to the video component.
Yeah, and you can reach back to me, I have my email. I can share it again, if you have any more questions. Yeah.
Yeah, and of course the link to the slides is posted as well, and will be posted with the video recording so that you can study those. And feel free to reach back out to Swati or to me. Yeah, there's her email,
Yeah.
Swati Satturwar at osumc.edu. So very good. Well, thanks again, everyone, for joining, and thank you, Swati, for a wonderful presentation. And we'll have to definitely do this again sometime to cover those atypical small acinar proliferations. And we will look forward.